I must first thank my old friend Tuncay Duros to invite me once again in Turkey. It's always a pleasure to be there. I think he asked me to speak about the history of ankylosing spondylitis because I'm at this time the oldest rheumatologist in exercise. So I have some experience of the history of the disease. It's a very old disease. Since it's possible to find some lesion in the mummies in Egypt. But the first real description of the disease was done on a skeleton by O'Connor at the end of the 17th century. He writes his discovery in French, in English, in Latin, so he was very proud of his discovery. But the first mention of the very specific pain at night were well described by the French poet Paul Scarron, who was the husband of Madame de Maintenon, who became later the wife of the King Louis XIV. The pain of this man was so important, it was written on his grave when he died, "Passant, don't make noise. It's the first night the poor Scarron can sleep." But the real description are done of the four Greeks in the pre-radiologic era. It was Strumpel, Pierre-Marie in France, Vladimir Betcherev, and we must also mention those who have described the first aspect of reactive arthritis, that is Fissinger in France and Reiter in Germany. They was on the both parts of the France during the war, the First World War. And they describe oculo-uretro-Saint-Marvel syndrome. From this period of antiquity to 1954, we can speak that this is the middle age of ankylosing spondylitis. It is the X-ray era. X-ray allows the description in 1931 of sacroiliitis by Krebs and of syndesmophyte by Sicard and Forestier. It was the first step to reduce the delay of diagnosis. Until 1954, the treatment of this disease was limited to aspirin, amidopyrin, radiotherapy, very used on the back, injection of thoriomics. Of course, the efficacy of all these drugs were poor, with many side effects. But many large series of patients were described by doctors like Forestier working in spa station, like Aix-les-Bains, Bath in England, everywhere. Of course, all this disease was very, very severe. Despite this description, until 1944, ankylosing spondylitis and rheumatoid arthritis were really orphan disease. They were not taught in medical school. The only rheumatic disease taught at this time was rheumatic fever, all articular tuberculosis, neuropathic arthritis, and gout. I've never heard about ankylosing spondylitis during all my medical studies. The first event was the discovery in 1954 of phenylbutazone. This drug was the solvent of a very old analgesic, Perros analgesic, amidopyrin. But by chance, the solvent was in fact the first NSAID. And it was the new era, the era NSAID. Of course, today, phenylbutazone has been suppressed. But at this time, phenylbutazone can relieve sacroiliac and axial pain. Joint movement are easier if stiffness does not result from bony ankylosis, and phenylbutazone is able to limit and even stabilize the radiologic evolution. At this time, it was something so important than today, the biologic treatment. But now this drug has disappeared. But this new drug have led the European rheumatologists to propose the first criteria for the ankylosing spondylitis description. It was the Rome criteria published in 1960. I don't want to describe all this thing because it's quite old form of spondylarthropathy, but it was the first description. And 6 years later, in New York, they published the New York criteria, which were in fact the birth act of ankylosing spondylitis in the United States, because it was the recognition by the US rheumatologist that rheumatoid spondylitis was not a variant of rheumatoid arthritis. And we will see that this means a very important later. 1973 is a very important turning point in every kind of the disease. First, it was the first description of the enthesitis as a target of the inflammatory process. Second, it was the expansion of new NSAID, like diclofenac, like indomethacin, like ketoprofen, etc. And also, it was the first synthesis of new drugs allowing safer and longer treatment of NSAID, that is, the proton pump inhibitors and cimetidine. It was so the treatment can be prolonged a long time. It was also the first time total hip replacement was done in ankylosing spondylitis, even in young people. The lumbar and cervical deformation were treated by osteotomy, and this was possible to correct very severe invalidities. It was also in the same year the description of the association of HLA-B27 with ankylosing spondylitis, description by Brewerton in UK, by Bluestone in US, and by myself and Jean Dosset in France in ankylosing spondylitis and Reiter disease, that is reactive arthritis. So this year was also a physiopathologic era. The concept of spondylarthropathy emerged. In fact, many years ago, in 1954, a French author, Jean Marche, has written that spondylarthritis and Reiter syndrome was two aspects of the same disease. So he has the very good idea of that. And I read at this time the paper of Marche, and this was the fount of my research with the work of Harkness in England concerning non-gonococcal arthritis. Because when we see the relationship between reactive arthritis and ankylosing spondylitis, we try to find triggering factor of the disease. It was a period where we looked to many different infections, like pseudopulmonal-like organism able to produce arthritis in rat and cattle, chlamydia in the urethra found in non-gonococcal urethritis, Shigella and Yersinia found in post-dysenteric reactive arthritis, and there is a long story of Klebsiella, but I think we must forget it. And now we are speaking about oral and ancestral flora as possible triggering factor of the disease. At the same time, the structure of B27 was achieved, and the 25 subtype of this HLA gene was also achieved. This allows the transfer of the human gene to rats, especially to Lewis and Fisher rat. This was done by Torog in 1990. But only Lewis rat have arthritis, enthesitis, and skin lesions. That show that non-MHC genes are also involved in the disease, that intestinal flora is important because them-free rats were not affected, and that the antigen-presenting cells, T cells, CD4 plus cells, were also involved in the disease. So between 1954 and 1950, modification in clinical presentation of the disease was clear. For example, reactive arthritis were less and less frequent. At this time, we saw practically no reactive arthritis. Why? Because it's a period of peacetime, no war, safe drinking water everywhere, and treatment of non-gonococcal arthritis. We saw also during this period that, in fact, both sexes are equally affected, despite differences in clinical presentation. Because previously, it was said that only men were affected. And more important, the severity of the disease has, in France, I don't know here, in France, has dramatically decreased. The incidence of prevalence remains the same. Despite the difference in clinical presentation, the genetic background is the same, HLA-B27 and psoriasis, but it's clear that environmental factors are involved in addition to genetic predisposition to modulate the severity. 1990, to take into account all this modification, it was time to propose and to validate new criteria, mainly based on clinical symptoms and using words comprehensive by a patient. It was what we called the 12 entry criteria, or the Amor criteria, because I have described this criteria. 6 points are just as necessary to have a definite spondyloarthropathy. As you see, it's word in clinical symptoms. A patient can read that easily, and there is very few. It's possible to have the diagnosis without X-ray lesion. That is important because these criteria are able to classify all disease aspects in both sex and even in childhood, even undifferentiated spondyloarthropathy and non-X-ray spondyloarthropathy, which have been described more recently, but it was possible to recognize this form long time ago. They can be used as a diagnosis tool. It's a kind of checklist comprehensive by a patient, even they are not, of course, diagnosis criteria. These criteria were the basis of the next criteria, the 2 entry criteria described by ESSG, European Spondyloarthritis Study Group. I work with them, but I think this ESSG criteria, we divide the spondyloarthropathy into 2 classes, are not better than those who were proposed. And we have now the ASAS criteria. I'm not going to develop this criteria now, but I think they divide ankylosing spondyloarthropathy in different subsets. That is useful for pharmacological investigation, but it's not helpful for clinicians. Please, I say, don't continue to develop new criteria. I think it's a loss of time. So this previous orphan disease is now recognized as a social plague everywhere. In France, they are classified as affection de longue durée, ALD, affection de longue durée. All fees are reimbursed 100%. And there is very strong patient association, very active. So the delay for diagnosis are progressively reduced, but are even sometimes too long, because some doctors are not confident enough in their clinical expertise and needs absolutely the support of radiologic evidence. But some others are not able to read by themselves the X-ray lesion, especially the IRM lesions. So they are in the hand of the radiologist, We have never seen the patient. So there is people who see the patient are not able to read the X-ray, and the other have the X-ray and not able to have never seen the patient. This is the reason sometimes to lose the time for the diagnosis. During the period following the 21st century, there is new trial of drugs. Salazoperine was tried for a long time. Lot of study. In fact, the efficacy were quite poor, only in ankylosing spondylitis with peripheral involvement and probably those associated with psoriasis. Anticox-2 was a wrong progress with RHR defect. Thalidomide was, of course, forgotten now, but it was the first drug targeting TNF. So it was, in fact, the era of TNF-alpha inhibitors. During this period, until now, synthetic biology can redesign biology system to achieve a particular purpose. Phage, a virus infecting bacteria, are able to introduce a fragment of DNA to obtain a specific antibody from this DNA. Mice transfected with the DNA of human TNF-alpha gene develop an arthritis simulating rheumatoid arthritis and may be cured by monoclonal antibody anti-TNF-alpha. The development of the half-mouse, half-man chimeric antibody gives rise to infliximab. Infliximab trials were conducted in Europe in rheumatoid arthritis and in Crohn's disease. But in United States, since rheumatoid spondylitis was still accepted by the FDA as a variant of rheumatoid arthritis, some ankylosing spondylitis patients were also included in the protocol and were dramatically improved. That allowed the introduction of infliximab in the treatment of ankylosing spondylitis. But in France, the patient was treated by infliximab in the controlled study. After 2 years, when the drug company stopped to provide the compound, infliximab was not approved for ankylosing spondylitis by the French authority. So the hospital refused to pay for the treatment. But by chance, patient associations were very active at the military level and helped to solve the problem. During the last 20 years, the Fage-Zipley technique allowed Winter to identify a fully human anti-tumor necrosis factor monoclonal antibody, which led to D2E7, that means adalimumab, and also the TNF-alpha receptor gene, that is etanercept. Since this technique has been used to develop a host of monoclonal antibodies, some of them improving also ankylosing spondylitis treatment, as anti-IL-17, secukinumab, mainly ankylosing spondylitis associated with psoriasis. They also give insight in the physiopathologic mechanism of the disease. So, 9, the diagnosis of the disease is in its different clinical presentation can and must be made very early, before the development of structural lesion. Information of the patient is crucial. Treatment must begin by NSAIDs, and biologics are needed in the case of inefficacy or uncontrolled side effect of NSAID. Physical activity must be maintained or prescribed. Today, patients with a spondyloarthropathy can live, many of my patients can live without pain, without ankylosis, but with the help of treatment. A total recovery without treatment, is it possible? Some patients can remain pain-free without treatment during long period, but relapse practically occurs in most of the cases. Is the story of spondyloarthropathy closed? One of my patients was 14 years old when I see him for the first time. He was a very severe ankylosing spondylitis with bilateral hip joint ankylosis. Total hip joint replacement was done for the first time in a very young patient. He was only 20 years old when we done that. He's today 60 years old, still active, and still treated with NSAID. That means that he have received NSAID for 50 years. So the story of spondyloarthropathy is not finished. That is now the job of younger rheumatologists to continue this story. Thank you for your attention.